thank you for inviting me. I have the honor and distinction to be the lecturer between you and the lunch. So without any further ado, let me go over left atrial appendage occlusion. I had some research with both Boston and Abbott in the past 24 months. Let's start with the first study that was published, which was PROTECT AF. You have to remember this was the era before DOAC. So it was use of the first generation Watchman versus warfarin. And this was a non-inferiority trial, and it showed that essentially the device was non-inferior. And when they followed up to 5 years, it showed superiority of the device over warfarin. And the two curves, as you can see, really separated around 36 to 42 months. And by 5 years, there was a superiority of the device. So 5-year follow-up of PROTECT showed superior efficacy and reduced mortality and similar overall safety as warfarin. It has to be mentioned that PROTECT AF did not end up getting approval for Watchman, and the reason was the concern for pericardial effusion and initial safety endpoints, and that's why a PREVAIL, which was a second study, which was done, meta-analysis of these two studies together, showed similar all-cause stroke and less cardiovascular death compared with warfarin. Interestingly, there was no superiority of these devices to a warfarin when it comes to ischemic stroke. However, there is significant reduction in bleeding-related strokes and essentially cost with Watchman over oral anticoagulation therapy. Subsequently, EVOLUTION trial was done in Europe that looked at 1,025 patients. Out of these 1,025, more than 1,000 of them had successful implant, and they had about 90% of them that they were able to follow, and they looked at post-implant therapy. In Europe, they started to use dual antiplatelet therapy much earlier than here in US, and as you can see, post-implant, 60% were on dual antiplatelet therapy immediately, and at essentially 6 months, you can see that 55% were on single antiplatelet therapy and 28% on dual antiplatelet therapy. And the use of oral anticoagulation therapy was only 27% at the time of implant and only 8% at 6 months. If you look at the risk reduction, and this is not risk reduction compared to oral anticoagulation, this is risk reduction compared to expected risk of ischemic stroke or TIA based on CHA2DS2-VASc score. There was an 84 to 85% decrease in chance of ischemic stroke, but this is if they were on no anticoagulation therapy. If you are looking at Hasbled, essentially there was a relative risk reduction of 50% when the patient was on oral anticoagulation therapy. The second device that was used much earlier in Europe than in this country was ACP and then subsequently ACP Amulet. The enrollment of 22 participant centers, all in Europe. And this was done 15, 16 years ago. So they looked at more than 1,000 patients in this study. And the success of full implant was 97%. They had high CHA2DS2-VASc and Hasbled was above 3. Oral anticoagulation was used only in 3.8%. and rest were on single or dual antiplatelet therapy. Major bleeding was only 1.2%, and the stroke was 0.9%. Cardiac tamponade was much less than the initial PROTECT study and was only 1.2%. Again, when you're looking at risk of the stroke and bleeding reduction compared to historic CHA2DS2-VASc score, you can see about 60% reduction in bleeding or in stroke when with these devices. The next generation devices was essentially Watchman Flex. This is the device that has been used until recently, and now they are coming with Watchman Flex Pro that I'm going to go over it shortly. This was a single arm, non-randomized study design. They looked at 400 patients in 29 US sites, and they were looking at safety and effectiveness of Watchman Flex. Post-procedure, now we are at the era of DOAC, so it was DOAC and baby aspirin for 45 days, dual antiplatelet therapy up to 6 months, and then aspirin indefinitely. They have done T at 45 days and 12 months, and they followed this patient up to 2 years, and they published when they had 12 months results. Primary safety endpoint was all-cause death, ischemic stroke, systemic embolism, and they defined, like every other left atrial appendage occlusion devices, the success as the peri-device leak of less or equal to 5 millimeter at 12 months. And the secondary endpoint was any ischemic stroke or systemic embolism. If you put it in the perspective of previous studies, the safety endpoint was fantastic. If you look at the previous studies, it was much higher. Issues here, there was only 0.5% risk of complication. Compare it to PREVAIL or even CAP studies, which was continuous access for PREVAIL and PROTECT AF, the complication went down from 2.2% to 0.5%. And if you're looking at less than 5 millimeter leak, all of these patients had less than 5 millimeter leak. The conclusion was the left atrial appendage closure device met the safety endpoint with 0.5% of patients experiencing safety endpoints, so essentially 2 out of 400 within 7 days post-procedure, and they had 100% closure defined by less than 5 millimeter leak at the time of implant and follow-up. So here, as you can see, majority of these patients were on oral anticoagulation therapy, DOAC, which was essentially, if you add these two numbers, is about 97% of them, majority on apixaban and or rivaroxaban, and discontinuation of oral anticoagulation therapy was about 96%. Look at discontinuation and put it in perspective of all of the previous studies. We went from 87% to 96% with this next generation devices. Flexibility was a study in Europe that looked at real data. So this is not a vigorous now clinical trial, and they still had 99% procedural success, and zero leak was achieved in about 88% of this population. So again, 94% of these patients were discharged on dual antiplatelet therapy. I have to mention that in US at the time, it was oral, it was DOAC and aspirin. Across the Atlantic, it was always dual antiplatelet therapy. So that's why 94% were discharged on dual antiplatelet therapy. And then we get to SURPASS study. As you know, all of these left atrial appendage closure devices that is done goes through NCDR. So we have a very large data on left atrial appendage occlusion. The SURPASS analysis looked at all of these patients that were done across the country. They looked at 16,000 patients who were considered for Watchman Flex devices between 2020 and 2021. So you see there is a large number of cases that has been done in less than a year in US. So what has been the difference in design of these two devices? On top, you can see Watchman. They have these tines which are open. So when the deployment is different because you cannot push it in the appendage and you have the risk of causing perforation. So you had to deep seat the sheath and then essentially deploy it. Whereas with the next generation, they closed those tines and you can make a ball and then push it, and it's much safer and much faster to do it. There are greater number of struts, and they decrease the metal exposure, which has advantage of less risk of clot formation or device-related thrombus. So SURPASS looked at occurrence of ischemic stroke or systemic embolism 24 months post-implant. They had a bunch of additional endpoints such as death, stroke, device-related thrombus, and device embolization. Out of these more than 16,000 patients, 97% were implanted. Only 2% were not implanted. They lost 13% in follow-up from the data that they have. What was the most frequent reason of not doing it was anatomy, which was not conducive for implant, and appendages, which were either too small or large. Again, this is real time data. This is all of the operators with different level of experience across the country. As you can see, death was 11 out of 16,000, so 7 per 1,000. Stroke was 9 per 1,000, and it was almost no hemorrhagic stroke. It's like 1 out of 16,000. Major bleeding was about 1 per 1,000, and device embolization was extremely rare with this device, was 2 out of 16,000. If you are looking at the LAA closure assessment, you can see that post-procedure, all of them had success, which was defined as less than 5 millimeter. If you look at 45 days, 99.6% had a leak of less than 5 millimeter. If you look at perfect no leak closure, it was 95.3% at the time of implant and 82% at 45 days. Again, pericardial effusion requiring either surgical or percutaneous intervention was 0.3%, and need for surgery was 1 per 1,000 at the time of implant and 3 per 1,000 at 45 days. So let's compare these results with Pinnacle. Pinnacle were a bunch of people who were experienced. Obviously, that's why they were chosen to be part of the trial. And SURPASS is all comers. And when you're looking at the data, the safety endpoint was really not much different. All that was a little bit higher in SURPASS, although as you saw, it was very, very rare. Stroke and ischemic stroke was a little bit higher in Pinnacle Flex. So even in the hand of non-experienced people, I think they have done a great job, and that's because of the better training and everything. And device-related thrombus, which was 0, is now 0.2%. which putting it in the perspective of the first generation Watchman, which was about 3.7%, this was a major improvement. In summary, it was a large number of patients, average age quite high, 76 years, 40% were female, and CHA2DS2-VASc score was high, and successful implantation was 97.5% with less than 1% risk of 0.9% risk, 0.9% risk of death, so essentially less than 1, and very small risk of ischemic stroke. And DRT, putting in the perspective, was much less than the first generation Watchman. So there was a meta-analysis of observational data showed there was no difference in the occurrence of stroke, major bleeding, DRT, all-cause mortality in patients with short-term oral anticoagulation therapy or dual antiplatelet therapy, because some of these patients were on dual antiplatelet therapy following left atrial appendage occlusion. Another thought-provoking was that some people said, okay, we are using dual antiplatelet therapy. Is dual antiplatelet therapy really less risk of bleeding, especially in people who have GI issues? Is there any other alternative option? And they tried to use half-dose DOAC, in this case, half-dose Eliquis, to see if there is any difference. So they looked at 555 patients in this study. They closed left atrial appendage, and they used half-dose DOAC and looked at it compared to dual antiplatelet therapy, and they showed even lower risk of device-related thrombosis and essentially major bleeding in this group. So their suggestion was that, and this is the era of DOAC and aspirin for 45 days, followed by dual antiplatelet therapy up to 6 months, and then single antiplatelet therapy. Their suggestion was, why we just don't use half-dose DOAC and aspirin for 45 days and then go up to 6 months with half-dose DOAC. So it's an alternative if you think that the risk of dual antiplatelet therapy is high. And then we get to the other device, which is Amulet, which was this second company which got an approval of left atrial appendage occlusion device. And these are the only two devices that are available in the US. If you go to Europe, there are multiple other devices that are available, but in this country, the only two devices which has been approved are these two devices that we are talking about. This is a large IDE trial, looked at 1,878 patients, which were randomized to Amulet versus Watchman. It has to be noted that this was the first generation Watchman. So you cannot really, it's not fair to compare it to the second generation Watchman, because second generation Watchman has advantages over the first generation Watchman. With Amulet, the decision was to try to use dual antiplatelet therapy. At the time with Watchman, we could not use dual antiplatelet therapy, so majority of those patients were on oral anticoagulation therapy. 95% with Watchman were on oral anticoagulation therapy. On the other hand, Amulet, about 80% were on dual antiplatelet therapy. And if you're looking at using dual antiplatelet therapy, device-related thrombus was, it was not significant, but you can see it was a little bit less in Amulet. TIA was similar. Hemorrhagic stroke, again, there was not much of difference, and all-cause death was less in Amulet compared to the first generation Watchman. So they looked at three primary endpoints, which was all the closure at 45 days, which was 99% with Amulet and 97% with Watchman. Safety at 12 months, again, very similar, and effectiveness at 18 months, which was very similar. Amulet achieved superior closure over the Watchman device, and despite the reduced rate of procedure anticoagulation, DRT, stroke, and major bleeding rates were very comparable. So the conclusion was, compared with first-generation Watchman device, LAAO with a dual seal mechanism using the Amulet occluder demonstrated non-inferior safety and effectiveness with superior left atrial appendage occlusion. So what about device-related thrombus? Because that can become a problem. There is a study that looked at the first-generation Watchman. They had 1,800 patients, and when they looked at them, majority of these patients didn't have any device-related thrombus. However, in 65 out of 18, more than 1,800 or 1,700 with successful implant, they had device-related thrombus. What are the observations with the device-related thrombus? What are the risk factors when they did a multivariate analysis that increases the risk of device-related thrombus? History of TIA or CVA, permanent atrial fibrillation, vascular disease, larger left atrial appendage diameter, and low ejection fractions were the risk factors when they did a study and looked at it. Now, if you look at ischemic stroke or systemic embolism, of course, you can see a difference between DRT negative and DRT positive groups in this study. However, if you compare it with risk of ischemic stroke, if they are not treated, and even add the DRT positive patient, you can see that there is a huge benefit of using these devices. So what are the clinical implications? Following left atrial appendage occlusion by Watchman, DRT is 3.7%. Now compare it to the second generation, which was only 0.2%. So there's a huge improvement. When you have the DRT, there is threefold increase in risk of CVA or systemic embolism, but is not associated with increased risk of all-cause mortality. Why? Probably because these strokes or TIAs are much smaller than the stroke that happens with the open left atrial appendage. Interestingly, 75% of the patients who had DRT did not experience a thrombotic event. So we don't know how to distinguish which patient with DRT has a higher risk of stroke versus not. But if we see it, we have to treat it because there's a threefold increase in risk of CVA or systemic embolism. DRT accounted for about 10% of all ischemic CVA post-left atrial appendage. And now we have the third generation of the Watchman that's coming to the market, which is called Watchman Flex Pro. So I think they used Apple and they went from Max to Max Pro. So they have to use the same thing and they have a Pro. What's the difference? The Pro, they come with a 40 millimeter device because the limitation is if you have a large orifice and you need to have at least 10% compression, you are not being able to close some of the larger ones. And so it allows to treat the widest range of anatomies, and they coated it with some material to prevent, and this is an animal study, to prevent the thrombus formation. So are we going towards single antiplatelet therapy? I hope that we get to the day that we can use a single antiplatelet therapy, because the reality is we still have situations that patients cannot even tolerate dual antiplatelet therapy for 6 months, and they have bleeding, and then we put one of these devices and they start bleeding on dual antiplatelet therapy, and now we have a really tough situation to deal with. From all of these data, right now, the recommendation that you have is if you're using Amulet, you can go with a dual antiplatelet therapy from get-go. With the Watchman, you have two options. You can go either with a DOAC and aspirin for 45 days and then switch to dual antiplatelet therapy, or you can go with dual antiplatelet therapy, and then both of them are asking for single antiplatelet therapy, which is aspirin 81 milligram going forward. Now, none of these studies looked at the DOAC. The era of DOAC came, all of the PROTECT AF, PREVAIL was the era of warfarin, and then they compared device against device. So the question is, if we use DOACs, are these devices still better than DOACs? And that's the subject of Catalyst trial, which is still ongoing, which is looking at randomization of 1-to-1 between Amulet and DOAC. And it's a slow progressing, essentially, study, because patients who are doing well on DOAC, sometimes they don't want to go through this, and patients who are not doing well, they want the device. They don't want to go through any randomization. In conclusion, multiple studies have shown efficacy and safety of dual antiplatelet therapy in this population. The use of LAAO in the era of DOAC is under investigation. Residual leak, do they matter? And how much is too much? There are schools of thought that they say, oh, all our studies done with leak of less than 5 and leak of less than 5 is okay. There are some data that shows any leak can increase the risk of having events, and there are school of thoughts that, oh, any leak is important, or, okay, if the leak is 1 millimeter, it's different than if a leak of 4 millimeter. And there are procedures that can be done to close these leaks, such as going and coiling the leak, or put a plug to try to completely close these leaks. But we don't know. Residual leak, do they matter, and how much is too much? DRT is definitely associated with higher risk of ischemic events. However, majority of these patients remain asymptomatic. And as I said, we need a better stratification of DRT and risk of ischemic event post left atrial appendage occlusion. Watchman Flex Pro has been coated with a thromboresistant coating that hopefully significantly decreases the risk of DRT, and we should not worry about the DRT. The jury is still not out. Thank you.